Okay, so welcome to this ARMA-hosted webinar on developing a JSNA focus on musculoskeletal health. These webinars are delivered in partnership with NHS England, and we've got three presenters today who will be outlining, Ian and Rutuja, who will be outlining how the JSNA was developed in Ealing and how it can be used. And Kevin Fenton will be talking about the wider public health context and MSK. So I'm going to invite Ian to introduce the webinar. Thank you, Ian.
Great. Hello, thank you and welcome. My name's Ian Bernstein. I'm a GP, musculoskeletal physician and clinical lead at NHS Ealing. And I'm joined by Rutuja Kulkarni-Johnston, who's a consultant in public health at London Borough of Ealing, and Professor Kevin Fenton, who's Director of Health and Wellbeing at the London Borough of Southwark. The outline for today, we're just trying to get the slides to move on. Sue, could you just come through and help us with the slides are not moving? Okay, so this slide is an outline of the webinar, and that's on the screen. We're going to start with a definition of musculoskeletal health. Kevin is going to talk about why we need to have a joint strategic needs assessment focused on musculoskeletal health, and then we'll look at how we developed it and how it's being used to implement strategy and policy locally. During this preamble, I'd be really grateful if you could download. We have two versions of the Ealing JSNA, a short version and a full version that's referenced. The quickest way to get to those is if you Google Ealing JSNA MSK, as it says on the screen, and you should find the top couple of links. And if you could just download those and have those open on your desktop for reference whilst we're talking. So how would we recognize good musculoskeletal health? Well, a person would need to be supple, have good muscle strength, sturdy bones for those muscles to act on to allow movement, a nervous system that can coordinate movement, and mental motivation to be physically active. And this would allow a person to be physically active without pain, stiffness, or fatigue. And more so, somebody who has good musculoskeletal health would be able to fully partake in their daily living and their working life and other activities of daily living if they are not at work. Musculoskeletal conditions comprise about 200 heterogeneous different conditions affecting joints, bones, muscles, spinal conditions, and autoimmune diseases such as rheumatoid arthritis. So I'm going to pass over to Kevin.
Thank you very much, Ian, and good afternoon, everyone. It really is a pleasure to be here with you this afternoon to discuss musculoskeletal health. I'm going to begin by reflecting a little bit on why this is a major public health issue and some of the work that we have been doing in Public Health England, but creating the connection between national work on musculoskeletal health with our national partners with what needs to be done locally in terms of developing effective programs within local authorities, within CCGs and our local community partners to improve musculoskeletal health. Now, musculoskeletal conditions really account for a leading cause of years of life lived with disability in the United Kingdom. And in fact, it's the third largest cause of disability-adjusted life years in the United Kingdom today. Each year, nearly 10 million people are affected by musculoskeletal conditions and poor musculoskeletal health. And nearly 20% of the general population consult a GP about a musculoskeletal disorder. 8.5 million people have osteoarthritis, which is expected to increase to about 17 million by 2030. And musculoskeletal conditions are the third largest spending area for the NHS, accounting for nearly £4.7 billion of expenditure in 2013, 2014. So from a public health perspective, we are interested in MSK and musculoskeletal conditions because they're costly and they're growing. And this growth is being fueled by demographic change. It's being fueled by our aging population, rising levels of physical inactivity, as well as rising levels of obesity. And as we illustrate here in the slide, significant proportion of the populations are seeing physicians about MSK conditions, and the cost to the NHS, nearly £5 billion per year. Now, one of the other areas of concern for musculoskeletal health for us is the impact on economic productivity. MSK conditions are the second largest cause of days lost in work after coughs and colds. And typically, this may present as back pain for workers, but may present in a range of other clinical complaints and conditions. In 2016, over 30.8 million working days were lost due to musculoskeletal conditions. And again, this accounts for nearly 22% of sickness absence and is costing the economy £7 billion per year. So whether looking at this from a health perspective or looking at this from an economic productivity perspective, we can really see the importance of musculoskeletal conditions. Now, a key element of responding to the challenge to musculoskeletal health is both understanding the prevalence and burden of the condition in the population, but also recognizing what are the tools available for us to both advise individuals, but also to advise the system, the health and care system, to respond to this challenge. Clearly, we can think about at the individual level what we should be doing to promote healthy living across the life course so that people are becoming more physically active and showing that we're continuing to promote physical activity across the life course to ensure that muscles, bones, and joints, as well as mental benefits of physical activity, are gained. There's a strong interaction between mental well-being and musculoskeletal health as well, not only because musculoskeletal conditions may result in poor mental health and well-being, but having good mental health is also important for promoting physical activity, having a healthy diet, having a healthy weight, all of which can impact on the risk of acquiring musculoskeletal conditions. Clearly, at the individual level, we can promote healthy eating for nutritious diets to maintain healthy weight and to ensure that intake of vitamin D, whether through diet or other means, for example, daily supplementation, are part of the advice that we should provide as well. And of course, a good part of healthy living is ensuring that there's effective sleep as well. So a range of things that we can do to promote healthy living at the individual level to reduce the risk or the consequences of musculoskeletal conditions. As far as the system is concerned, there are a number of other key activities that we can be focused on as well. And this slide from Public Health England, Health Matters, just really illustrates the range of partners which are involved in improving our response to musculoskeletal conditions and in promoting MSK health. So commissioners, for example, have a role to play in providing and commissioning training to improve the skills and competencies of the workforce. And of course, commissioning evidence-based interventions for people with musculoskeletal conditions. I really believe that the voluntary sector has an important role to play, in part because of the significant contacts that they have with members of the population and helping local communities to shape and to influence policy decisions regarding musculoskeletal health. Local government clearly has a role to play, in part because of our commissioning of a range of health, well-being, and lifestyle and preventive programs, but also through health in all policies to look at ways in which we can work across councils to ensure that musculoskeletal health, promoting physical activity and well-being, are being seen as a cross-council priority. Professionally, Royal Colleges and associations have a role to play in supporting effective pre- and postgraduate education on musculoskeletal health. And throughout their careers, healthcare professionals also have an important role to play to ensure that they make every contact count with patients to promote musculoskeletal health and to raise awareness about MSK risk factors and interventions. So we all have a role to play in addressing musculoskeletal health and improving our response to these conditions, whether at the individual level or at the system level as well. I'm now going to hand over to Rutuja, who will take you through the Joint Strategic Needs Assessment and how this approach to musculoskeletal health can be made real and effective at the local level. Thank you.
Hello everyone, my name is Rutuja Kulkarni-Johnston and I worked with Ian Bernstein, who you heard earlier, in getting the MSK Musculoskeletal Health JSNA ready for Ealing. I'm going to be talking about the purpose of the Joint Strategic Needs Assessment as we view it and how it's viewed in legislation. So as you know, it's a statutory duty for local authorities to produce a Joint Strategic Needs Assessment, and it was first noted in many different ways. Public health is mentioned in legislative acts, but the first mention of it as a needs assessment was in the 2007 Local Government and Public Involvement Act, where it says an assessment of needs must be prepared by local authorities in conjunction with local PCTs. When PCTs were abolished in 2012, the Health and Social Care Act came in, and again the statutory duty was expected of local authorities in producing needs assessments along with the clinical commissioning groups. It describes the health and social care needs of the population, as we all know, and it contains locally topic-based and theme-based chapters. And the musculoskeletal health chapter is one of the latest, along with others that we've done around smoking and end-of-life care. We have a program for updating chapters on a rolling basis, and a new development for us locally in Ealing is the Focus On series, which is a very succinct summary of the chapter. As you might expect also, that it is useful for commissioners and professionals. This is part of the statutory requirement that it informs the joint health and wellbeing strategy and actions related to that. It's also of use for the public and service users. It informs people about the decision-making process and feeds into the accountability. Health and wellbeing boards and commissioners can use the public health outcomes framework and the CCG, this is clinical commissioning groups, outcomes framework to assess any progress they make as a reference point. And this is also within the statutory requirements, and accountability and transparency of decision making is part of that process. I am now going to hand you back to Ian to go through the next section, which is on what guided us in preparing this JSNA.
So before I put the next slide up, I just want people to have a look at some of the eye candy on this slide. So this slide, we've used as the backing for this, the Focus On series slide presentation. And across the bottom, you can see the main chapter divisions. So the Focus On version is a short version. It's got 16 pages. And you can see the types of headings. The Focus On version is produced as a PDF, and those are clickable links along the bottom that enable quick access to different parts of the document. And it's aimed at non-specialists, so commissioners who may not have a special interest in musculoskeletal health, so that they can get a quick overview. The main document that guided us with both the 2014 and the update in 2017 to the JSNA is the Arthritis Research UK's document called Musculoskeletal Health, a Public Health Approach. And this was really a sea change in the way Ealing developed their MSK JSNA. Up until that point, the JSNA really described a disease process. But this document from Arthritis Research UK opened our eyes to looking at the prevention of disease and disability, the promotion of musculoskeletal health, and using a life course approach. When you look at the full JSNA, you'll see that there's a series of tables which reflect that life course approach, and they identify the gaps that relate to what we currently provide, and the recommendations again fall into that life course approach. In updating the 2017 JSNA, there's two further documents from Arthritis Research UK. The State of Musculoskeletal Health has got a wealth of information about different diseases and topics related to MSK health, and the last document on that list, musculoskeletal conditions and multimorbidity, are really key to addressing our aging population and the issue of comorbidity. Also on this slide are the main statistical sources, and when we get to the reference slide you'll actually have links to these sources. There's a few that I want to highlight here. The musculoskeletal calculator gives us local area information about the prevalence of osteoarthritis and low back pain. Kevin has referred to some of the global burden of disease data, including disability adjusted life years and years lived with a disability. This data can now drill down to regional level. So for us, we were able to look at Greater London data. There are, of course, the fingertips health profiles published by Public Health England. And lastly, I want to discuss this bottom reference, which is about the return on investment. So if you look across the bottom of the slide, you'll see the last 2 or 3 links. First of all is gaps. What we mean by gaps is identifying areas of service provision where we're not performing as well as we could, and also areas where we're simply not yet providing a service that people feel that we should be providing. In order to make a recommendation, which is the next link, that has to be linked to evidence. So it has to be linked to an identified gap, and it has to be linked to the other evidence about what works clinically and what's cost effective. Recommendations need to be smart. That means that they must be specific and not aspirational, that they are measurable, achievable, realistic, and the realistic bit is what relates to the return on investment, because it's very easy to say that something is clinically and cost effective and we should then spend money on it. But the reality, the constraints of the current NHS is that unless some of these recommendations are cash releasing, i.e. that they produce a return on investment in future years, it's very unlikely that they will get actioned. So that last document from Public Health England is a key document. So I'm going to hand back to Rutuja just to drill down a little bit more about why we produced 2 versions of the JSNA.
Thank you, Ian. So I'm going to go through what we did in the production of those 2 different documents and take you through some of the stages and add a bit more meat to the bones that Ian's sort of gone through with you. So the main document, which if you've got in front of you, you'll see is fully referenced with original references included in it. And the focus version is a shorter version of it, obviously, and doesn't have the full reference list. So if you wanted the original references, you need to go to the main document. It's set out in 8 sections, and although it looks like it's 7 on screen, it's set out in 8 sections. And there's an executive summary which captures what each chapter does and then goes into the detail of each. So I'm going to tell you a little bit about what Ealing has done. Kevin's already highlighted to you the national picture around epidemiology and the pathophysiology, as has Ian. But in terms of Ealing, the local epidemiology reflects the national. So we have more women who are affected, we have more minority groups who are affected, and also people working in particular professions who are affected as well. So that's just a sort of overview. You can see the detailed picture in the actual chapter, I wanted to give you a little bit more about the level of need in Ealing. So we have some 55,000 people in Ealing who suffer from lower back pain, some 35,000 who have osteoarthritis of the hip or knee, and also we have some 87% of those with chronic pain who have another significant medical condition. And from the SUS data, what we were able to establish was that in 16-17, we had some 1,300 admissions for falls alone in Ealing. We also have some 1,400 people claiming incapacity benefit, which is related to musculoskeletal health. So we have got a fair level of burden of disease locally. And another thing that we're looking at, which Ian's already mentioned, I think, is that we have differential referrals. When we've looked at services that we're providing, he's referred to the gaps that we've looked at. And one of the things we notice is that there is different rates of referral amongst GP practices for MSK, for musculoskeletal conditions. So that's something that we need to look at and see what we could do easily in a sort of realistic way. In terms of promoting health and preventing musculoskeletal disability, we're recommended, we're asked to, and to have musculoskeletal health, one needs to look at promoting physical activity and also helping people stop smoking. Those are the main preventative interventions that can be undertaken. At a Northwest London level, what we've done is also looked at the plans that are in place to address long-term conditions like musculoskeletal health, and looked at the plans that are there to transform musculoskeletal health at that regional level. We've looked at the current interventions and assessed them for, as Ian has highlighted, whether they're effective clinically or on a cost basis, and also whether they're giving us value for money. We've benchmarked ourselves against like areas and found that there is the variation in referrals. And also we know that from NHS Right Care that we have high levels of readmission for elective as well as emergency admissions for orthopedic surgery. So we've looked at all of that, and that's led us to identify the needs that are emerging in Ealing. And they are really that we need to improve our levels of physical activity, maybe particularly to address certain groups, women and certain ethnic minority groups. Also, we need to look at whether we can increase falls prevention services, look at fracture liaison services, and also a community pain service, as well as looking at preventing readmission. And the top high priority recommendations, there's some 8 of them that have been suggested in the JSNA, and they include some of the ones that I've already mentioned, as well as reducing obesity, including support for people on mental health, so IAPT, involving access to psychological therapies, and also looking at whether we can bring our the services for musculoskeletal health more based in the community rather than working through hospitals, based on appropriate referrals and clinical integration. Ian's already referred to the focus on version, so I won't actually go on very much about that, but just to say that it was a way of creating a brand so that it's recognizable locally, that this is a short version that people can access locally and understand the decision-making processes and identifying needs within Ealing. And it obviously invites a wider range of audiences beyond the commissioners and the professionals. We do look at our JSNA cycle on a 3 to 5 year basis and review and update it as and when the time is for looking at them. I'm now going to hand you over to myself. I'm sorry. Sorry, there's a next slide is me as well. And this is about looking at the governance and provenance framework that we had set up to complete this chapter. We involved authors who had the expertise. So Ian himself obviously was the original author to this chapter, and there were some public health staff, analysts, as well as CCG staff who led on certain sections of the chapter. We have oversight in the JSNA steering group, which has membership from senior members of the CCG, including Ian, directors of children and young people, adult social care, strategy and engagement in the local authority, performance, as well as the analytical team. Health Watch are also a member of this group. We had peer review internally through this clinical executive of the CCG, commissioning managers and various other leads, as well as through public health team and council officers. We did have feedback from adult social care commissioners, among others, and we had Health Watch carry out a survey with users of the service to find out what they thought of the service. There were our community services for musculoskeletal services, like the falls prevention service, carry out their own user feedback survey to look at quality of services provided, and that's also included within both the short and the long version of the JSNA. We approached GPs for their feedback and also voluntary groups. The Northwest London STP transformation programme had an opportunity to comment, and the original chapter, which was devised in 2014, which was written in 2014, had method analysts looking at it. The Health and Wellbeing Board were presented with the chapter in January 2018. It got sign-off from them and has been published since in February. I'm now going to hand you over to Ian to look at the next section. Thank you.
Thanks, Rutuja. So this slide is about how we have implemented the JSNA, and hopefully will demonstrate how a JSNA chapter can influence and inform the development of policy. So on the slide, you can see that there are 4 things that I've highlighted, which I'm going to talk to. So the first is the Ealing standard. The Ealing standard is an enhancement to the General Medical Services contract that GPs provide, and it went live on the 1st of April this year. It contains a number of disease areas and a number of service lines that are consistent with moving care from hospital into the community, and it goes beyond what GPs would normally provide. Now, in order to, and the funding for this, because it requires extra staff to deliver this, the funding for this comes from the 5-year forward view promise to move funding from hospital into primary care. So I'm just going to give you some examples of activities that GPs are expected to do under this contract, and you'll see that this was informed by the JSNA. So GPs are expected to be proactive about signposting to support physical activity and weight loss for people who are at risk of musculoskeletal disorders. We've mentioned the increasing risk of falls, and we've talked about fall services, but GPs have not been particularly proactive until now. GPs are now being asked to undertake falls assessments and make appropriate referrals in 3 groups of people: those with fragility fractures, those who they've identified as having moderate or severe frailty, and those who have a history of falls or near falls. We've also asked GPs to be more proactive about providing occupational and activity modification advice for those people who are at risk of losing work due to musculoskeletal disorders. And we recognise that there's an increasing burden of patients with chronic pain and that services are scarce, and therefore there is a requirement to manage patients with chronic primary musculoskeletal pain in primary care. In order to support that quality standard, there is an education and upskilling programme delivered by the community education provider, the CPEN. And again, the JSNA is important in bidding for funds for this, so that over the coming year, we can roll out an education programme for healthcare assistants, nurses and GPs in primary and community settings of care. Some of you may know that Ealing is going to reprocure its community services in total under a single contract. So this covers not just musculoskeletal services, but adults and children's nursing, falls services, and a whole range of services. The business case for this, which is being scrutinised in detail by NHS England and NHS Improvement, is heavily dependent on the evidence provided in the JSNA chapters, not just the MSK chapter, but all the JSNA chapters that relate to the out-of-hospital services. And finally, the STP, the Sustainability and Transformation Plan, which is basically, when it was first written, was the sum of all of the health and well-being and JSNA chapters of the 8 constituent CCGs. That STP has a musculoskeletal transformation programme, which again is heavily informed by the Ealing MSK JSNA. So the JSNA is a live document. It doesn't sit in a bottom drawer. And one of my roles within the CCG is to make sure that as services are being commissioned, recommissioned, re-evaluated, that the contracts managers and the service development teams are pulling out the latest JSNA chapters and checking the headline recommendations. So I'm going to pass you back to Rutuja to talk about implementation in a different area.
Thank you, Ian. I should say, actually, in Ealing, public health are looking to increase physical activity levels amongst all of the populations across the life course. There's also opportunities. We currently commission Strength and Balance program within the borough, and there's opportunities going forward for in enhancing that provision. So previously I worked in Royal Borough of Windsor and Maidenhead in Berkshire, and certainly at the time, this is in 2013-15, the process was to work with commissioners to write the JSNA. So commissioners were involved in writing chapters that related to their specialty. But following writing, sorry, I shouldn't say but, also following the writing of the JSNA, one of the key things that we did was run workshops with heads of service and commissioners to look at the key recommendations that were falling out of the JSNA and to have a discussion around what could be prioritised. I understand, and I don't think the consultant head of the service lead is able to attend today from Windsor and Maidenhead, but I was told by this is Teresa Salami Oru in Windsor and Maidenhead that they actually are continuing with the process of involving commissioners and heads of service end to end to make sure that recommendations are picked up on and can be held to, people can be held to account to see progress against the needs assessment. I know that also Newham, where I worked, they used the children's needs assessment to commission their early years provider. They were going out to procurement. So there are certain steps that are taken elsewhere too. And we are following in a similar way in Ealing. Thank you. I think Ian picking up the next.
So we're on to the home straight. We will send out the slide pack after the webinar. I've put the key references for this presentation on there, and obviously there are more references in the detailed JSNA chapters. We're going to turn off the screen share and move into a discussion mode. So at the moment, Sue has the screen, I think. So Sue, do you want to guide us through what we need to do? And I'm going to ask my colleagues to just come in so that we're all on screen.
Yeah, so we've got one question come in already, which I'll come to in just a second. And if people have other questions, please do type them into the questions or into the chat box, and we will pick those up. I know we have a number of people on the line who are in the process of working on a JSNA around MSK for their area, and we will also email you with information about how you can use our brand new MSK Knowledge Hub to have conversations with each other about your experiences. So we'll let you know about that as well. And also, I should have said at the beginning, we will be tweeting about this webinar using the hashtag MSK JSNA. So the question that has come in is, how has the uptake and feedback been on the Focus On series from local partners and stakeholders?
So I think Rutuja and I will pick up that answer. So from a CCG perspective, it's been incredibly welcome. People who just were really put off by a heavy document have found it very refreshing to look at visually presented infographic style JSNA, and actually were able to take home and repeat the key messages about the health needs and the recommendations. Rutuja, do you want to add anything?
Yes, so we've used it internally to get feedback, and certainly that's been very positive within the local authority from commissioners and from public health team. We've published the JSNA on the website now, and we'll be going back to our engagement and strategy team to find out what has come back from that in the next month or so. So that's the plan, to review what comments and feedback has come through from the public while reading it.
There was also some feedback from the Health and Wellbeing Board. Remember, they have a statutory duty to review and publish the JSNA chapter. The feedback from councillors, who are obviously not experts, even those holding the health brief, they found it very refreshing, very easy to get to understand the key issues, and they were very encouraging, said it was a refreshing approach.
So there's a follow-up question here, which is, has this led to any specific policies relating to prescribing and enforcement and or promotion of social prescribing?
So, so there's two separate questions there. So with regards to prescribing, there are, as part of the pain management across the STP, there is a programme looking at reducing harm from medication for people with long-term chronic pain. That there is some reference to that in the full version of the JSNA, but it's not a key, it's not a high priority recommendation for Ealing, but it is happening at STP level. The issue about social prescribing is interesting because there is some dispute about the data. Rutuja's been working on social prescribing, so do you want to pick this up?
Yes, I suppose in the Northwest London STP level, there are quite a few CCGs who've signed up and are working on this, and we know that across London as well as nationally, there are a few CCGs who are keen on the social prescribing programme. Within Ealing, the business case that went through is still, I think, being looked at. I don't think it's progressed as much as a commitment has been developed. There was business case was about running a pilot with certain number of practices to see how it would work. So we're waiting for that to progress, as Ian's referenced, that actually it's looking at other developments and bringing those in to make sure it's a robust system that we put in place. So it's a wait and see game for the moment.
I think the issue is that the evidence is conflicting. It's very easy to cherry pick the evidence and say that it works. A paper was brought to the CCG clinical exec in the last 6 to 8 weeks, and it did not go through because the clinical evidence and the cost effectiveness evidence wasn't robust. And with the current financial constraints, it was very unclear that there would be any return on investment at this time.
That's great, thank you.
Yeah.
We've got a question here which may be outside the abilities of our panelists to answer, but I'll give you a try. The question is, how will the proposed move to 100% business rate retention affect the provision of physical activity and MSK services? Does anybody feel equipped to answer that one?
So
Everyone's looking at...
to take that. As you are aware, there are proposals to change the ways in which funding for public health and for local government will operate in the future with the retention of business rates. My understanding is that there is still a lot of work being done to really clarify the degree to which the public health ring fence will continue. And if the public health ring fence does not continue, what relationship will then proceed in terms of funding for public health from the business rate retention. So a lot of work is going on behind the scenes. I think we have to watch this space. The most important thing is that we continue to invest in effective and cost-effective and evidence-based prevention programs, that we continue to advocate for those programs with local politicians, with local partners, and that we continue to demonstrate the impact of those investments in terms of return on investments, so that if and when we switch to business rate retention, we will have a very good case for continued investment and in fact increased investment in public health. So in summary, I'd say watch the space and continue to do good work and demonstrate the impact of your work.
Could I add to that? Just as something, picking up on something that Kevin said, working with local partners. We've sort of, for instance, in Ealing then, worked with transport team and our planning team to try and get them to look at how it affects physical activity, social isolation, and bringing that on, which would in turn have an impact on musculoskeletal health. They affect each other. So influencing other wider determinants that are being put in place, so local environment, access to green space, access to sort of safer environment so that people can be outside and be physically active, is something we can continue. And in the meantime, whilst this national picture is emerging around funding.
I think that's such a great point, and it then underscores why adopting a health in all policies approach is so important, because it means that not only are you looking at the monies within the public health ring fence, but you're leveraging resources which are coming across other sectors, both in local government and I would also argue in the CCG, but in total place, looking at all of those resources and looking at how you can leverage those to improve musculoskeletal health. So completely agree with what you've just said, and a health in all policies approach is a really good way of thinking differently about resourcing.
And I'd just like to chip in that the health and wellbeing strategy, the 5-year strategy for Ealing, does exactly make that point, that health needs to be much more embedded in all policy areas of development within the council. Sue?
Thank you very much. Which I think is a really nice summary of why for me this webinar is so important. And I was so pleased that we could do it, because the JSNA really should bring together the public health and the NHS understanding of what the MSK needs now and in the future are. And I think without that public health and the health in all policies, then coping with the MSK, rising needs of MSK with an ageing population is going to be a real challenge. So I think this is a really, really important webinar, and I'm pleased that we've had lots of people joining it. We haven't got any more questions, so I'd just like to thank you all for being willing to come and present on this, and hope that people will continue to work on this, and we'll use the MSK Hub to continue sharing good practice. And I'm looking forward to seeing lots of exciting MSK content in JSNAs in the future. Thank you all very much.
Thank you.
Thank you.